All right, thank you, Lisa, and thank you also to Catapult Education for being able to host this webinar. I sincerely hope that everybody who's in attendance here and those that are watching on our broadcasted/recorded webinar really receive a lot of wonderful education and information about overdentures. And those that know me know that I'm almost insanely passionate about implant overdentures as just this incredible way of restoring patients. And this presentation is going to be focused pretty much on implant overdentures as a treatment modality, and then also more about the advanced side, about what I've been doing in my practice, about implant number, looking at strategically how we go ahead and pick up these attachments and parts and pieces, as well as the clinical steps and procedures. I'm going to go ahead and get started here. Additionally, like Lisa was mentioning, if you have any clinical questions, feel free to type them into the box. We'll have time here at the end of the webinar to be able to address questions. For a little bit of information about me, feel free to check out my website, michaelscheerdmd.com. But I am a full-time clinician in Northern California, a small town, only about 5,000 people in my small town, just outside of San Francisco. And I'm also a part-time clinical instructor at University of Nevada, Las Vegas, and I teach in the prosthodontics department at Loma Linda in Southern California. Additionally, I'm a board-certified prosthodontist. And with this presentation, I acknowledge Implant Direct for being able to support this presentation. I have a tremendous amount of experience using these implants, and it's just a really wonderful implant system. There are some additional online resources available for this presentation I encourage you to check out. Check out my website, michaelscheerdmd.com/publications. And then also I maintain 5 YouTube channels on a variety of different dental concepts, and 4 of them are dedicated to implant overdentures. So I encourage you to check that out, michaelscheerdmd.com/YouTube. The whole reason we're here this evening, or here in California on this afternoon, is to talk about our patients, how we could better the lives of our patients by thinking of creative ways of utilizing implant overdentures, as well as utilizing implants in creative positions to better serve our patients. The whole point of what we're doing here is to improve our patient's quality of life. And this is just a patient who came to me in my clinical practice for a consultation. He came in saying, Doc, I heard that you repair these dentures, and, I had this one tooth break off here, and I did the best I could, put a little bit of super glue in there, shove the tooth back in, but hey, I'd like for you to come take a look and see what you can do to help me fix this tooth up. So routine in my clinical practice, whether it's for new patients or for any patients that do require some treatment, is that we do a full workup, and we do full face photography, side profile pictures with and without their teeth if they're wearing dentures or removable partial dentures. Additionally, we do inside the mouth photography, where we get to have a chance to analyze as well as interact with our patient, dynamically being able to enhance the communication ability of what we're doing with our patients, and then also to facilitate their understanding of what we're thinking about to best serve their treatment needs, whether their treatment needs are limited, like our patient initially here, or from a more comprehensive situation or from a comprehensive background. What's interesting in this clinical presentation, however, is you can see here on the screen, we're trained in dental school to look at arches, look at keratinized tissue, look at our bone conformation. Is this patient a good candidate for implant overdenture treatment or for any sort of implant treatment? Well, clearly this is a patient missing all of their teeth. And a patient that is missing all of their teeth, in my eyes and in my book, is always a candidate for some sort of implant treatment to improve their quality of life. I do a tremendous amount of removable dentures, as well as implant overdentures, full arch, fixed cases, hybrid restorations, all on 4, all on 5, all on 6, etc. But denture patients I really enjoy treating because it's extremely rewarding. What happens with these patients is that they come in, and a lot of them have concerns about denture stability. Maybe they're tired of teeth falling out, flopping around all over the place. This patient came to me for a limited problem. But take a look here on the computer screen. You can see here that, yes, like I mentioned before, we're training dental school to look at the arch conformation. Is this a good patient for a plain denture? Is this a good patient for an implant overdenture? Could I put a couple of implants in here? Easily. But really, this patient came to me for a limited exam. But we have to think beyond just the limited exams, because take a look in here. We can see here that I see across the board these little pink areas sticking out here, here, and in here. And that's denture adhesive. Even though this patient came in with this limited problem, I asked them, okay, do me a favor, take out your upper and lower teeth. And he says, well, doc, here's the upper denture. Oh, that's all you need to do to fix this tooth. I'm like, yeah, no, not a problem. We'll be happy to fix that tooth. I'll get it fixed up for you in a jiff. But as a courtesy, I'd also like to go ahead and offer no cost to you. I can clean your upper and bottom teeth, before you go. Oh, sure, doc, here we go. You can clean this up for me. And no joke, I did not make up this picture. The patient hands me his denture, and he's got this wadded up almost tissue on the lower part of his anterior ridge of his lower denture. And he's got the stuff in his upper denture. To me, this is a prime opportunity for us to start talking and engaging with our patients about implant overdenture treatment. And this patient, even though he came in for a limited fix, I said, hey, what's going on with all this stuff that you've got here in this, lower denture? He says, well, doc, it's a lower denture. I says, no, I don't know. Tell me why you're doing that. Oh, well, I need to put that in there so that way my teeth don't flop around here on me. And this is our opportunity. Even though that, yes, this is terrible, looks disgusting. We can fix up this patient, make this patient look better. But instead of this patient walking out with just a limited treatment fix, moving on to continuing to use loose floppy dentures, this patient left that day accepting implant overdenture treatment. And this is something that I see on a day-to-day basis in my clinical practice, because I know that my greatest challenge is to provide a removable prosthesis with adequate retention, support, stability, so that way the patient has an improved quality of life. And we know that there are well-recognized benefits of improving stability of our patients' dentures. Improved ability to eat, speak, confidence, gain nutritional benefits, no need for or limited need for denture adhesives and pastes, and additionally improved bone retention and related oral health benefits. It's interesting too, because a lot of people think, oh, my patients don't think of implants as a way of preserving their jaw bones. They just think of an implant as something scary, and they have to do surgery on. Well, no, I have a lot of patients in this very well-connected and well-understood society where patients are going on Google or going online and they're researching these things before the patient comes in. And if I have a patient that says, hey, well, doc, I heard that the implants can actually help keep my bone there. Is that true? Oh my gosh, it's like a gift when a patient asks this question, because it's absolutely true. And then it absolutely allows me to go into some of the advanced restorative concepts of utilizing more than just 2 implants for my overdenture cases. And that is a huge benefit for preserving what remains. Interestingly enough, even though implant costs are higher than traditional removable dentures, yeah, that makes sense. If you add implant surgery, the parts and pieces, the costs are going to be higher. What does that say about the patient? Do patients really find a quality of life difference even when money is a factor? And the answer is absolutely. The research, as well as my empirical or clinical experiences, is that I've had very few patients, even when money was a factor, say, you know what, really kind of sad that I did this. I could have used the money more than, having my teeth anchored down. Said by no one. The reality is the vast majority of patients report a immensely higher grade level of satisfaction for their dentures with implants. And yes, this is the statement that I just made. But the big question is that, yes, they are more expensive. The research shows that it's approximately 2 to 4 times the cost of a traditional complete denture. And how do we break that down? A standard complete denture, the national average based upon the 2016 ADA survey of dental fees for general practitioners, is about $1,600 for an arch for a complete denture. The mean or median for the implant placement is about $1,900. Surgical guide, $250. The locator attachments or abutments, $325 each. And then the implant overdenture, about $2,200. Now, this is also for clinicians that charge extra for an implant overdenture versus a denture, which I am not one of them. However, there are quite a few clinicians that prefer to do that. Maybe they say, well, I always put a metal frame in my denture, or it's a lot more technical, my laboratory charges more. Absolutely. The national average does show that there are clinicians who charge more for implant overdentures, and there's also quite a few clinicians who just charge the normal denture fee because all they're doing is essentially gluing a couple of locator housings to the denture, and they're still making a plain old denture. And that's me and my philosophy. I make a standard denture and then just charge for the attachments and the parts and pieces. In fact, I find it actually as self-serving as a dentist. We already know that it's going to improve the patient's quality of life tremendously, but it's also going to lead to less post-op appointments, less adjustments. So to tell you the truth, we're winning. Absolutely, both the patient and the doctor. But you can see here, there's quite a price difference between the two of these. Approximately 4 to 4.5 times more cost for these patients. Is it really worth it? Well, I kind of gave it away a little bit earlier in that earlier slide because the answer is yes. The research shows that the implant overdenture cost is initially higher the first year. However, it's amortized over a lifetime, and oral health quality of life improves by almost a third. And the research over and over and over again shows that trend. So what we find now is that if we start looking at how overdentures are growing, we know that, yes, many of you say, overdentures, why should I bother? Now, many of you that's tuned into this webinar already work with overdentures, already know the benefit of overdentures, but there's a lot of detractors out there that say, an overdenture, it's kind of a substandard prosthesis. What a, just what a bunch of business right there, because I can tell you that overdentures are amazing. Full arch restorations, whether it's implant overdentures, removable or fixed, is tremendously beneficial to our patients. And then the counter argument is, well, but doc, patients are not like that in my practice. Are there any people still missing all their teeth in this country and world? Absolutely. Even though the rate of edentulism has decreased every decade since 1960. The research shows that the baby boom population shift is resulting in a disproportionately higher level of patients missing all of their teeth. And what we find is the patients that are above the age of 65 also have a disproportionately higher level of edentulism compared to those under the age of 65. So we see a tremendous growth of the number of edentulous arches currently in our population. So we've not even plateaued on the number of edentulous arches to be restored in the United States. Think about globally as well. And what we know is that that population shift is still continuing for the next 15, 20, maybe even 30 years. What we know is that eventually we're going to plateau. We're not even at the plateau yet. So if we have a normal shaped curve, like a bell-shaped curve, eventually we're going to reach the top of that bell-shaped curve, and then we're going to start seeing less and less patients missing all their teeth. But for the foreseeable future, we are still at the growth potential for focusing in on complete tooth restoration, either with removable restorations or with fixed. So looking at your practice, even in high socioeconomic parts of the country, like San Francisco, city not far away from me, highest per capita income in the whole country. And the doctors there know that there are still plenty of patients in that area that have complete tooth loss and need complete arch reconstruction with removable or fixed restorations. So yes, if you're focusing on patients that are teenagers or you've got a veneer practice, you might not see these patients as much. However, what I do know is that if you treat one denture patient really well, they refer not just a couple, but they refer 10 of their friends. What we need to do is we need to figure out what we need to do technically, mechanically, treatment planning wise to figure out how to address this problem. What we know is that we have lots of different steps involved with how we treat these patients. And typically it's thought of a linear fashion where we're going to treat patients from the diagnostic ending up in the maintenance phase. In all reality though is it's a continuum. We see our patients throughout their life history. Now, sometimes what happens is that we get the patient all the way through the treatment phase into the maintenance phase, and they might re-enter the diagnostic phase, having to add additional implants, maybe to convert from a fixed to an overdenture or from an overdenture to a fixed prosthesis. So what do we think about with restoring our patients? Is a denture better than a fixed prosthesis? Is a fixed prosthesis better than a removable prosthesis? Well, some people genuinely believe in something called the good, better, best philosophy, where you take 2 implants versus 4 implants versus 5 to 6 implants, removable all the way up to a rigid solution, all the way up to a fixed solution. Now, some people do think that the fixed solution is the best, and for many patients, it is the best. However, for some other patients, a removable solution might be the best. So yes, as a general trend, fixed is usually a little bit better than removable. However, there are going to be quite a few patients that if you put them into a fixed restoration will not do well. So some of our removable restorative options for full arch complete edentulous patients are complete dentures, of course, the implant retained overdenture, which is a 2 implant restoration or 4 implant restoration that is tissue supported and implant retained. Notice I do not call this an implant supported overdenture. This is an implant supported overdenture, something that is rigid, multiple implants, and there's very little movement of the actual prosthesis. Sometimes there's a series of locks, swivels, plunger type attachments that are in place for these types of patients. However, all three of these are still removable. Fixed solutions include what you see here on the screen. Traditional fixed hybrid, sometimes known as an all-on-4 or all-on-5 prosthesis. A fixed immediate load prosthesis delivered the same day that the implants are placed. And additionally, the, quote, ultimate prosthesis, which is the PFM or PFZ restoration, which is individual implants where you have very natural transitions between natural pink tissue and porcelain tissues or white tissues. However, in my practice, the vast majority of my time is spent managing these two patient populations. Either the patient with complete edentulism, wearing dentures, that is interested in a solution to improve their quality of life, or the patient who comes to me with a failing dentition, soon to be edentulous. Now, typically in my practice, those patients are going to end up in usually one or two different camps. And most of the time, if the patient comes in, they're missing all their teeth, wearing complete dentures, usually going to end up with a overdenture restoration of some sort, either 2 implants or 4 implants for that patient. And typically the patient that is missing all their, or soon to be missing all their teeth with existing maybe maxillary reconstruction or natural maxillary teeth and needs reconstruction on their mandibular arch, this type of patient would be best served a lot of times with a fixed prosthesis. And there's a host of different factors that we won't go into all the nuances of each one of these categories, but there are quite a few things to understand from a treatment planning perspective when you're thinking about a locator versus a fixed hybrid restoration. Most importantly, implant placement is not really that critical for a locator or an implant overdenture. Now, that also kind of pains me to say that because I do genuinely believe that implant placement and angulation is quite important for a locator case in the grand scheme of the world comparatively to a metal ceramic or PFZ restoration that you want perfect papilla. You need excellent implant placement for those. But for a locator overdenture, if you place them at the 22 or 23 position, does it really matter? Maybe a little bit, but it's not that critical. The key is that we're going to look at the number of implants, and we're going to focus here on what you see for our overdenture cases. We want to focus on 2 versus 4 implants for our overdenture restorations. Also, we want to think about smile line for our patients that are missing all their teeth that might need some lip support. A overdenture would be a preferred prosthesis. And of course, as complexity goes up, cost goes up. So looking at our overdenture prosthetics and our overdenture philosophies, many of us are very familiar with this type of treatment modality. The 2-implant overdenture, anterior mandible, somewhere between the mental foramina or interforaminal space as we call it. It's universal, it's been around for a long time, it's proven, it's very safe. There's not a lot of nerve structure and blood vessels that concern us as much as it does, say, in the posterior mandible. And it's also quite cost effective. Additionally, the literature as well as my experience shows that a non-splinted implant reconstruction is equally effective as a splinted restoration. Therefore, historically, implants have been placed at the canines connected with a bar because we were so concerned about overloading the implants. What the research shows is that 2 individual implants with a stud style abutment, such as a locator, is an excellent restorative as well as a long-term solution for our patients. Many of us want to think about additional implants. Maybe you've had the experience of placing 2 implants here for a mandibular overdenture, or maybe even a maxillary overdenture, and you say, well, shoot, sometimes if I get 2 implants, I get some rocking back and forth. So you know what, let me just go ahead and pop a 3rd one in there so it's going to resist that kind of antero-posterior rocking. Now, yes, that is sort of true. It is a safe approach because you're also still interforaminal away from the inferior alveolar nerve and some undercuts. It is relatively proven in terms of reducing some of the rocking, and is it really cost effective? One thing that you have to look at is implant distribution here. The picture on the bottom is what a lot of clinicians end up with when they think, oh, I'm just going to pop in a 3rd implant. And in all reality, when you start thinking about how implants are placed, what I was able to show is that in some of the research that I published a few years ago in JOMI and JPD, if you have 3 implants that are narrowly spaced together, meaning they're kind of all clumped together like you see in the picture on the bottom, you actually get worse physical properties, meaning retention, stability, as compared to just having 2 implants widely spaced. Interesting. However, if you're able to achieve 3 implants placed like the picture on the top, where the implants are widely spaced, then you get really an improved type of physical property, meaning retention, reduction of AP rocking, as compared to just having 2 individual implants. And the reason for that is that the picture on the bottom functions kind of like a wobbly tripoded chair. If all 3 of those legs are really close together, it kind of rocks around a little bit. But if you have 3 legs that are really widely spaced apart, you have nice stability of that stool or leg or chair. And what happens is that I really kind of have some issues with the 3 implant situation. It's not a bad way to go. Do a lot of clinicians have success with it? Of course. Does it work? It does. But in all reality, if your intention of placing a 3rd implant here is just to reduce some of that rocking, to tell you the truth, I'd tell you to skip that. In my practice, I usually either do 2 or I jump right to 4. I really love the 4 implant restoration for my mandibular or maxillary overdentures. It has excellent stability. Sometimes it's too retentive, but the nice thing is with a locator abutment, I can easily toggle between different retentive nylon inserts, or I can even swap back to the black insert, which is not endorsed by Implant Direct or Zest Dental Solutions. However, there's a lot of clinicians that do utilize that approach. However, you can, swap around your abutments and your retentive levels if you need to. Additionally, you can use a non-retentive insert for our patients that have trouble removing these prostheses. The key here is that our implant distribution is important. We have to think about parallelism. It's still important that our implants be relatively parallel to each other. And then also, if you're thinking, well, if I'm going to place 4 implants routinely, maybe I'll just do a fixed prosthesis. Now remember, that sometimes is a spurious type of thought process, because the difference between a fixed and removable prosthesis is not always just the number of implants, but it has to do with the patient's desire, and then also the cost of the prosthesis. A fixed, quote, all-on-4 prosthetic or a fixed hybrid is quite a bit more expensive than a traditional denture prosthesis. So if a lab bill for a lower denture is somewhere between $300 and $500 an arch, the lab bill for a fixed prosthesis for a single arch can somewhere between $2,000 to $10,000 an arch. So you're talking a huge delta between your laboratory bill. Even though your implant costs could be the same, there's going to be a huge delta between fixed and removable. So in my opinion, if I'm looking at like an implant that costs approximately $200, $210, like a Legacy 2, Legacy 3 implant, the additional 2 implants is really not that much more expensive for my patients. If I figure out a way of doing that, pricing that, I find this incredibly beneficial to my patients. More on this a little bit later. First, let's go ahead and talk a little bit more about how we work with our actual housings and attachment systems. And the implants, once they're integrated, they're really pretty straightforward to work with. The key is that what are we doing with the stuff on top? And the key is for my clinical practice, I found a lot of experience or a lot of success with using the Locator abutment. The Locator abutment is essentially like a button that snaps onto a jacket. And many of us are familiar with the Locator abutment and how it snaps together. But how many of us are really that familiar with how a locator functions? If I took a locator housing with the pink or the nylon insert and I snap it onto a locator abutment, you can see here that there is something called dual retention. The inside here, the button part, and then the outside, or this kind of outside button part, are both engaging the locator abutment. So you get a snap here and a snap in here. That dual retention holds that nylon insert together really nicely to the implant and abutment. How many of us also are unaware that the nylon component of the locator abutment stays rigidly attached to the actual abutment? And what pivots or what moves is the actual metal housing inside of the denture. So imagine that metal portion is locked inside the patient's denture. If there's a little bit of bone resorption, or maybe the patient's really got squishy gum tissue somewhere, there's going to be some movement of the denture. That's to be expected. What happens is that this movement needs to be transferred to the implant somehow. Now what happens is that when that movement occurs on the outside part of that nylon insert, you're going to minimize the wear to the retentive part of the insert, which is inside here. In some other attachment systems where you don't have that pivot, you could rapidly accelerate wear of your nylon inserts. Now, the Locator abutment is available for the vast majority of our Implant Direct systems. Now, me in my practice, I use the Legacy system, Legacy 2 or Legacy 3. And you can see here that they make the Locator abutment for the 3.0, 3.5, 4.5, or the 5.7 millimeter platform for Legacy. How we would order it is I'll show you how to go ahead and measure the soft tissue depth, but we're going to choose our platform, which is set by my implant that it was placed by either myself or my oral surgeon, periodontist, etc. Then what I'm going to do is measure the soft tissue and choose either one of these numbers right here, and then I'm going to order this part number from my Implant Direct sales rep or online. Additionally, you have multiple different systems available for your interactive, also your swish, replant system. You can see Locator is available for all of these. And then also finally for your Spectra. For any of the clinicians that are, hey, I've got this other implant system, etc. Yeah, Locator is available for most of the systems. For the Implant Direct line, it's available for all of the Implant Direct lines within the systems that you see here, the two-piece implants. Now what we can see here is that we can also configure the nylon insert retentive level of our housings once we pick it up in the mouth or have the patient have the denture process in the laboratory. You have multiple retention insert level strengths. So the lightest is the blue insert, followed by the pink and clear for our normal range inserts. And you can see here, it's got a button appearance where there's like an internal button as well as the external button. So the least retention is blue, most retention is clear. Additionally, for highly divergent implants, we have extended range Locator inserts. Red is the lightest, followed by orange, followed by green. You can see here, you can match kind of the strength levels. So the red will be somewhere between the 0 and the blue. The orange will be somewhere between the pink and the clear, and the green will be just a little bit less than the clear insert. And what we can see here is that it gives us the ability to kind of test a few different levels of retention. It's easily hot swappable, so meaning if I go ahead and I pick up the inserts in the mouth and I try it in the patient's mouth, how's that feel, Mary? Oh, it feels great. Oh, but when I do this, I kick it out. Do you have something a little bit stronger? Not a problem. I pop out the blues, pop in the pinks, have her try that out. And she says, oh my God, that's perfect. Or maybe she says, oh my God, that's too tight. I can't remove it from my mouth. No problem. Pop those back out, pop the blues back in, and she's happy. Additionally, I can swap up to the orange if I want just a little bit level of increased retention level strength compared to the blue, maybe a little bit between the blue and the pink. Additionally, we have a gray insert. The gray insert is meant for 0 retention. So if I have 4 implants or 6 implants on the maxillary arch and the patient just has way too much retention, I can go ahead and dial down the retention by using maybe blues in the front, grays in the middle, and blues in the back, etc. Additionally, you have the extended range inserts, which are able to accommodate implant placement up to 40 degrees of total divergency, and the standard range will allow up to 20 degrees of total divergency. So the nice thing is with the Locator is that if you use a Legacy, Swish, or Replant, whatever one of the implant lines that you use, do you need implant specific Locator parts for that implant system? No, the answer is that Locator is universal to all of the implant systems within the Implant Direct library. So what we know is you can just go ahead and order anything that you see here on the screen, and that will be compatible with all of the Locator systems for all of your patients, depending upon which of the Implant Direct system that you use in your office. You can see here all of the different ordering numbers. You have a 4-pack or a 20-pack of the different levels of retention strengths, and then also you can order just the black processing inserts if you need those for a variety of different reasons. Now, most clinicians, what we do is we order what's called the male processing pack, which is this little pack that you see here. The male processing pack includes the metal housing, the black processing insert right in here, and then also includes 3 of the level of normal retention strength, so clear, pink, and blue, as well as the blockout spacer. So once we go ahead and figure out, okay, let's go ahead and review how we work with our implant systems and the locator abutments. Then we can go ahead and talk about some of the surgical procedures, as well as maybe thinking slightly outside of the box for our locator cases. So let's briefly discuss essential restorative protocols for our overdenture patients. For many of us in our clinical practice, if you're placing implants, or if you're not placing implants, working with a surgeon, dedicated surgeon, many times we'll see our patients back with our healing abutments in place, ready to be restored. The patient has had these healing abutments placed at the day of surgery, or maybe the surgeon did an uncovery and placed healing abutments and now is doing a, quote, restorative clearance. The restorative clearance means that the implants are ready to be worked on and we're ready to go ahead and do our denture procedures. So we have multiple different options available for our patients. Option number one is the patient's wearing an immediate denture. Patient's been wearing the immediate denture during this process. Maybe you or your surgeon went ahead, took out all the teeth that remained on their mandibular arch, placed 2 implants in canines in premolar positions, and then closed up using sutures, and then had an immediate denture ready based upon pre-prosthetic procedures before the teeth were extracted. At that point, I'd be looking at a patient with an immediate denture in place with a soft liner inside of their denture, typically something like a co-soft or a chairside soft reline material. The option that we have for that patient is we can either reline or rebase those dentures. If the patient is wearing their existing complete denture, maybe the patient came in, hey doc, I've got some money, I was really thinking I want to put it into just helping, feeling a little bit better with my lower denture, it's kind of flopping around, I think now's the time. I've been hearing about these implants, no problem. They're wearing their regular denture that they've been wearing for 20 years. Essentially, if it fits good, you don't have a lot of bone changes that you made, there wasn't a lot of healing, there wasn't a lot of shrinkage of the jawbone, you could just simply reline, meaning fresh tissue surface of the acrylic in the denture, either chairside or at the laboratory. And many times in my practice, a big part of my practice is taking out teeth and placing implants the same day that the teeth have coming out and the patient's wearing an immediate denture. So what you see here, number 2, is a big part of my practice. And that patient, a lot of times, had to have alveoplasty, alveolectomy, somewhere between 1 and 5, 6, 8 millimeters of bone was reduced prior to the denture being placed. And that patient has a huge amount of space inside of their denture. And those larger spaces typically needs to be done with something called a rebase procedure, meaning similar procedure. Instead, what you need to do is you need to go ahead and send to the laboratory. They're going to strip all the teeth out and essentially pour the acrylic, making a brand new tissue surface form. Or classically, the third option is the patient's got kind of an older denture. They're saying, you know what, if I'm going to do this, place these implants and just make me a brand new denture. Absolutely. Those are 3 great options of where we need to get going with our patient. So the simplest kind of laboratory pathway is what you see here on the left-hand side of the screen. Patient's been wearing this immediate denture with a soft liner in place. Typically what I'm going to do is I'm going to see the patient. I'm going to remove the healing abutments, place my locator abutments, then do a reline impression, basically taking the patient's immediate denture, removing the soft liner, washing the inside of the denture with whatever impression material you'd like to use, sending to the laboratory to do a reline impression or reline procedure, either picking up the inserts inside of the reline impression or processing them or picking them up in the mouth after the reline has been completed at the laboratory. So step number 1, we have our patient with our implants in place and healing abutments also in place. We're going to unscrew the healing abutment, and then we need to take a measurement of the patient's soft tissue depth. So what we need to do is take a periodontal probe or instrument, take the tip of the probe, put it on the side wall of the implant. In this example, showing a legacy implant. So I take my probe, feel from the top or the side of the implant itself, and then take a measurement. And you can see here on the right-hand side of the screen, this would measure 1, 2, 3 millimeters of soft tissue depth all the way around on the implant itself. And you can see here that not all ridges are made equal. Even though that if the implant was right here, you'd see 1, 2, 3. Maybe over in here, it might be 2 millimeters. How would we address that? Well, I'm going to show you that step right now. But this is just kind of a general protocol. I unscrew the healing abutment, take a measurement, and then the patient goes back home. What we do is we go ahead and we need to figure out the top of the implant to the top of the soft tissues. So right here is that same patient, legacy implant. We're going to measure from the top of this line right here to the top of the soft tissue. And that's going to give us a measurement. Why don't we call it H? We're going to order from our catalog corresponding to our implant system. This is out of the legacy catalog. We're going to order a cuff height that matches that number that is called H. So if H is 2, we're going to order a 2 millimeter matching with our implant platform. So this one right here is a 4.5 millimeter legacy. So purple and purple. I'm going to come over to here and I'm going to order this 8045-92-L. And that's going to correspond perfectly. Now, please don't think about it any more complicated than that. A lot of clinicians will say, well, if I measure from the top of the implant to the top of the tissue, then I have to add this for the locator and the housing and everything. No, just stop doing that. All you need to do is measure from the top of the implant to the top of the soft tissue, and that's the number that you order from the catalog. Now, if you have a change of your tissue, maybe one part is 3, one part is 2.5, etc. If you have kind of a spot in the middle, it's always better to order a little bit on the higher side. Now, if your number is 2 or 2.5 or 3, and you want to put in a 3 millimeter cuff height on a routine basis, absolutely, that's fine. Just do me a favor. If your number is like 3, just please don't order like a 5. Your abutment is going to be too tall. And what I've found in my experience is that when the abutment or the locator abutment is just way too tall, you will get more rocking of the denture. It will act almost like a kind of a pivot point if that abutment's too tall. Also, you need to go ahead and order your locator male processing pack. That's something that we need to order for our overdenture cases. We're going to include 2 sets of the parts needed. So our male processing pack for our standard range insert comes in a 2-pack. Now you can see here, why would they package it as a 2-pack? It's because typically most clinicians are going to be restoring in pairs of 2s, meaning 2 implant overdenture, 4 implant overdenture, 6 implant overdenture. However, if you do a routine number of implants, meaning an odd number like 1 or 3 or 5, you can order a 2-pack, and then you can order a single 1-pack of the standard male processing package. Now that is the standard range males. If you need the extended range male, they only come in a pack of 2. So that's something to keep in mind. Now that doesn't mean you can't order like one of these 2-packs and then order just metal housing, a couple of greens, etc. No, you can all order those a la carte just through your Implant Direct catalog. So once we go ahead and size our implant, the patient then either returns the next visit, or like in my office, I keep a stock of locator abutments as part of my implant stock because I don't really want to bring a patient back in just to do a soft tissue measurement. So I keep plenty of implant heights in my office. So that way I see the patient, unscrew the healing abutment, take a measure, and put in the locator abutments that same day. What I'm going to do is I'm going to remove the healing abutment. I'm going to irrigate the implant either with sterile water or chlorhexidine, dry the implant, and then I'm going to place my locator abutment. And now how you place your locator abutment is you use the core tool. The core tool is a three-piece tool that you can see here on the right-hand side of the screen. You're going to place your locator abutment using the triangle portion of the core tool. So at the bottom part right in here, or right in here, they're almost like a little triangle. That part engages the internal portion of the locator, allowing you to screw it into place. Now what you need to do is confirm your full seat of your abutments. We need to do that typically with a periapical, or in my preference, a panoramic radiograph. Trying to make a periapical radiograph on a patient with a locator or an edentulous arch is extremely cumbersome. It's not very comfortable to the patient. So as a routine, what I do in my practice is this, is I seat my locators, remove my soft liner, start doing my border molding, start doing my Reline Impression. Then I remove the denture, air dry it off, put adhesive on. Then while the adhesive is setting, I need about 5 to 7 minutes for the adhesive to set before I make the Reline Impression. During that time period, my assistant is taking my patient to go to the panoramic machine and to make a panoramic radiograph to confirm full seat. Patient comes back. Before I do my Reline Impression, I torque my abutments down. That workflow works extremely well in my clinical practice and is extremely efficient. Before I make my final Reline Impression, after doing a radiographic check that the abutments are down all the way, I torque. I'm going to use the torque wrench with the hand adapter, which is the torque driver that you see on the top part of the screen, which is my preference. It's my favorite torque driver ever. What I do is I use this specialized torque driver because it's got a spring-loaded torque driver on it. If you still have one of those little kind of breakaway torque drivers, I highly encourage you to kind of start thinking about making the transition to one of these spring-loaded. The research shows that the spring-loaded torque drivers are much more accurate and reliable because they don't need to be calibrated and they're extremely predictable in terms of their torque levels and, frankly, very easy to use. What we need to do is we need to torque according to our implant-specific manufacturer guidelines, so make sure you look it up in your particular Implant Direct kind of catalog of what implant system. What I can tell you is the vast majority are going to be torqued down to 30 Newton centimeters. Make sure you check your implant system and your catalog prior to doing that for your particular implant system. How I torque that down is I use this torque wrench, and there's an insert that will accept one of these right angle or latch style drivers. Also, there's a square version if you'd like to, and it has a locator triangle tip on it. Place that directly into your locator abutment, pull your lever across until you hit the torque value that is correct for that implant system. Next step is we're going to place our locator housings. First step is we're going to place our blockout spacer ring. Then we're going to place our denture cap on top of the white spacer. Keep in mind, both of these are included in your mail processing package or your locator processing package. The next step is I go ahead and I remove my soft liner. As mentioned before, my workflows, I kind of start removing the soft liner before I do all that stuff. Just efficiency-wise, in my office works a little bit better, but this is kind of the classic way. Remove the soft liner using a burr, hot water, etc., whatever you find effective for you. Then I'm going to make a Reline Impression. A Reline Impression is essentially just what you see here. I take the patient's denture. It's a shell of what used to be there on the tissue surface. The tooth surface is not changing, meaning I'm not going to modify my teeth. I'm not going to cut back my teeth. I'm going to make sure that I'm going to do what's called a closed mouth reline or rebase impression. So I take my patient's shelled out denture. There is adhesive on that shelled out denture. And then I can do border molding if I need to with heavy body PVS, with green stick compound, isofunctional, you name it, I've tried it. What I'm going to do is I'm going to do a closed mouth Reline Impression, border molding, etc. My preference in my practice is to use a regular body PVS with some heavy body PVS border molding. Assuming that your denture is pretty close to being proper, meaning the proper borders, the proper controls, everything should be a pretty straightforward procedure. Many times you can use just the monophase or the regular body PVS without having to do a lot of border molding and do a good job. How I'm going to do this is I'm going to inject the PVS inside of the patient's intaglio surface of the denture. I'm going to seat that onto the edentulous ridge, have the patient bite down into centric relation or MICP. Then I'm going to have the patient tap, 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 tap a few times. Then I'm going to have the patient do border molding. I'm going to have them stick out their tongue, wiggle their jaw around, make a puckering sound, smile big, stick their tongue out, move it side to side. Sorry for the sound effects, everybody. Then I'm going to make sure that the patient's at the proper vertical dimension when they bite down. So sometimes I use a little bit of a stick marker, like on their nose or on their chin, just to verify all that's been done. And this is what your impression should look like. I want to inspect my impression for completeness, should have well-rounded intact borders, minimal voids and tearing. I must make sure that I have the outline of the denture housing and cap. The housing and cap might come out with the impression, and if so, remove it. So the general idea of what I do mostly in my practice to keep it so simple is I make a reline impression. A reline impression of the patient's edentulous ridge with their housings in place. I do not want the laboratory to process or to include or attach the locator housings in that reline impression. Let me repeat that. You can see here, I've got an impression of the patient's edentulous ridge at their vertical, at their centric, and a outline of the locator abutment inside of the impression. I send that to the laboratory. The laboratory pours a stone model that is going to be this patient's ridge with a metal replica of the locator housing. The reason why I do that is the vast majority of times I prefer to do a direct pickup of the locator directly in the mouth. I find it's much more reliable, much more predictable, and frankly, much cleaner. Some people will say, well, I just want my laboratory to do it because I don't want to mess with it. I make it quick, clean, and easy. I snap it in, I leave the room. Be careful with that. It can work, and if it is going to work, it's going to work best with a small amount of reline material here. Keep in mind that acrylic resin at the laboratory shrinks a lot. So if I have a lot of shrinkage and there's distortion of those locator housings, many times it'll snap in well on one side of the mouth, but on the other side of the mouth, it'll pop out really easily. And you're like, well shoot, this doesn't work well. And then all of a sudden you're like, well, overdentures don't work. The key is keep your life simple. In my office, I either do this or I do a chairside hard reline of the patient's denture, picking up the locator housing with the reline. Both of those ways are extremely efficient, very nice, and very, very clean. So a chairside hard reline is also a very nice way of doing this. My general preference, however, is that because I do a lot of immediate dentures and immediate implant placement, to do a chairside reline where there's just a shell, like this patient right here, a shell, this would be a challenging chairside reline to do because you'd have to really use a lot of reline material. It'd get really hot. It could lock in underneath undercuts. So for most of my practice, I do the reline impression. However, if I have a case where I don't do a lot of alveoplasty and a lot of ridge reduction, it's perfectly fine to do a chairside hard reline procedure. So now once the laboratory gives me what you see here on the screen, meaning housings that have holes cut out corresponding to the locator housings themselves, patient comes back to my office. The denture is now ready. I go ahead, place the same blockout rings, same denture caps with the processing insert, the black processing insert in it. And now I need to go ahead and size the recess. So the laboratory gives me kind of like a small hole that corresponds to the actual locator abutment. When they do the reline, you see the outline shape of the locator housing inside of the denture. You still need to create a little bit larger hole to accommodate some of the resin. If you just try to pop that in the mouth with the exact size of the locator abutment, you won't be able to get it down all the way. What I use is something called the Chairside Prep and Polish Kit. Very nice kit. Again, is available wherever you'd like to get it, but is also available from Implant Direct. And the top row here is the preparation burrs. The preparation burrs is the recess burr, which is a burr that's sized for the locator abutment, an undercut burr, and a vent hole burr. The bottom burrs are trim, grind, and polish, which is the polishing side. So what you would use after you glue the housings inside of the denture. The top row is to prepare the recess, so that way the abutments and the housings are able to be seated. And this works for locator as well as a variety of other different overdenture attachment systems. So if you do use a different type of abutment, a different type of attachment, it can work perfectly well. And then also you can use a reline material like a composite resin with like what you see here on the screen, also available from Implant Direct. It is a composite resin. There's not a lot of shrinkage, not a lot of smelly stuff, ideal handling. It's dual cured. If you want to add a little bit to it, it can light cure on itself, easily bonds to itself. And then additionally, you have low curing temperature, odorless, tasteless, and extremely simple to use. So what we're going to do here is just kind of go through a little bit of the video. I'm just going to kind of turn down some of that audio. And for our friends at Catapult, if you're getting a lot of that audio showing through, I apologize. We can just turn that down. So the general workflow, what we're going to do here is this is just a video off of my YouTube channel. Feel free to go check it out. But what I'm going to do is just go step by step. First step is I remove the healing abutments. I'm going to remove the healing abutments, exposing the implant underneath. Then what I'm going to do is I'm going to irrigate the implant itself, just kind of cleaning it out, flushing it out. Then what we're going to do is take a measurement of the soft tissue form. As mentioned before, I'm going to measure from the exterior portion of the implant to the top of the soft tissue. I got a measurement here, and that measurement is about 3 millimeters. Then I'm going to take my locator abutment, lightly screw it on top of the implant itself until it's just finger snug or finger tight. Then what I'm going to do is repeat for the other side. Unscrew my healing abutment, or I can use this as the core tool just to show you what the core tool is to tighten that down. I'm going to remove the healing abutment now on the other side. Now everybody also make note. I have any of my instruments that are going to go in the mouth, I'm going to tie them off with a floss, or I'm going to use a 2x2 just in the back of the throat, so that way we don't run the risk of accidentally aspirating or having a patient decide to make something lunch or dinner. Irrigating the implant, placing my locator abutment, and tightening down with my locator core tool until it's finger snug and finger tight. Now at this point, we're just going to go ahead and take the patient for a panoramic radiograph, ensuring that those implants are down all the way. You can see here the implants and the abutments are properly seated. Now what I'm going to do is I'm going to go ahead and I'm going to torque that down just using my torque wrench, tightening it down all the way until I reach the torque value for that individual implant system. Kind of jump forward here for a second. There we go. Now what we're going to do is we're going to place on our blockout rings or blockout processing spacers. What I like to do is I like to take that just on my fingers and just lightly tap it down over the edge. Don't push it down all the way. You want to see just over the edge of that kind of little exterior prominence. Then I'm going to place on my housing itself. The best tool that you have to ensure that your denture is passive over the top of these locators is just your fingers. Measure it with your fingers, try it back and forth, because a lot of times you will feel the metal binding. Same thing here, we're going to repeat for the other side. I recommend doing 1 implant at a time, or if you're doing 4 to 6 implants, I recommend doing in series of 2s, meaning I'll do the whole left side once, and then I'll do the whole right side after I've sized the abutments or the housings, the recesses for the right side. Now what we're going to do here is we're going to go ahead, try that denture in again, verifying that it seats down all the way. And now what I need to do is just size my recesses. To size the recesses properly, I use the either the denture prep and polish kit or any commercially available acrylic burrs. And then I like to go ahead and utilize a PVS-like material. This is just showing you a white PVS called Fit Checker. And this material will just kind of go inside of the denture, show any areas of contact of the denture to the metal itself of the housing. I take a red pencil, just mark that little area of show through. And then what I'm going to do is just kind of size my recess appropriately using a series of burrs. Then what I'm going to do is I'm going to drill a hole through the lingual or the palatal of the patient's denture. And it'll show it right here. As I'm drilling a hole through the palatal or the lingual aspect of the denture, it's going to create what's called a vent hole. The vent hole is going to allow for excess material to flow. Drilling through the buccal or the lingual, depending upon which is the most thin. You can see here I've got a couple of holes that go right into where my recesses are. The idea of that is that as I'm ready to kind of inject my composite material in here, I only want to fill it about 2/3 of the way full. My assistant air dries the locator housing very, very well, or you can use a 2x2 to kind of dry it off really well. Okay, here comes the air again. Take a little bit of our material, place it on top of the housing if you like. Just don't use too much. You only want to use enough acrylic so that way it just picks up the housing itself. I'm going to seat onto the edentulous ridge, and my preference is to go ahead and hold the patient's denture down with my fingers. I don't really like having the patient bite down into centric or into MICP while we're doing this pickup procedure. And many of you might be saying back saying, well, that's the way I learned. Isn't that the way that you're supposed to do it? Keep in mind, ask yourself the question, how many times if you ask a denture patient, oh, bite down, do they bite kind of goofy? Like, oh, there's my teeth sticking out, or they go into protrusive, or they might bite down a little bit goofy. Absolutely, like every denture patient will do that. So in all reality, what happens is that if you have the patient bite down while this material is setting in their mouth, there's a very good chance that they're biting a little bit harder on the right, a little bit harder on the left. Maybe there's a little occlusal prematurity in your denture that you didn't know about, causes the denture to kick up a little bit off the ridge. My preference is to hold the denture down, so that way I can ensure that I've got a denture intimately flush to the soft tissue. Many of you will say, well, I'm a little bit scared because then I think the bite's going to be off. I can tell you after doing this, I can't even tell you how many times I've done this. Approximately 9 to 9.5 times out of 10, I'll very rarely have to adjust the occlusion. And if I do have to adjust the occlusion after doing this procedure, just holding the denture into place, chances are my bite was wrong in the first place with the denture. Interesting. So if I can ensure that I've got the denture properly seated on top of the soft tissue ridge, it ensures that I have a fully soft tissue supported overdenture. If I have the patient bite down and it lifts the denture up a little bit, it's going to glue the housing at that higher spot. And then when I snap the denture back in on the mouth, it's actually going to be lifted off the soft tissue on that side, causing it to be more implant supported than implant retained. The clinical effects of that is that if you have more implant support to your locator, you're going to have accelerated wear of your nylon insert, or you might not feel a good level of retention strength with your blue or your pink inserts. Once I've had that material set up fully, I remove it from the mouth, and you can see here I had a perfect pickup. A little bit of excess material has flowed out the lingual, exactly how I want it to look. Now what I'm going to do is I'm going to use some of my composite resin, just kind of filling in some of those little grooves and those little voided areas. I'd rather have a little bit too little than a little bit too much for my initial procedure, because I can always add some of this material. If you dry off your locator housing really well, there's a very good chance that you're never really going to have to worry too much about not picking these things up. The only time that you miss the pickup is if there's saliva or moisture contamination during the composite resin injecting into the denture, meaning that the patient goes, oh, what's this? And they push their tongue right on top of the locator abutment. Now at this point, I can use my locator core tool, remove my black processing insert, and place my nylon retentive insert. And most of the time, I start out with the blue or the lightest possible insert for my patient. Until proven otherwise, approximately 90 to 92% of my overdentures are retained using the blue insert. The other about 5 to 6% is the pink insert. And then the last few percentage points are a mixture of the clear or the extended range male inserts. If you find yourself going to the clear a lot more often for your cases, it's important that you check out your technique. Notice there that I was testing the retentiveness of the patient's denture. I'll just kind of jump back a little bit. It's important that after you do your pickup procedure, or if you have the laboratory process it, I'm going to make sure I put my denture in. I want to feel it snap in. Now you might not always get that noise or that click. When it's in the mouth, that denture should be pretty stable. Even though the locator abutment is meant to kind of pivot somewhat, the vast majority of the time, even with a 2-implant overdenture, there's not a lot of movement of your patient's denture. If the procedure is done properly, if the denture is done well, this is what it should look like. There shouldn't be a lot of movement of the denture when the patient sticks out their tongue, smiles really big, or bites down on one side. So now let's take the last few minutes of our presentation here to kind of talk about some of the advanced concepts in overdentures. What we know is that many people do purport that the minimum standard of care for overdentures is a 2-implant overdenture. Now for me, I don't agree with this consensus, and I say it publicly. And the reason why is that I just don't like putting the word standard of care on something like this. In my office and in my practice, my personal standard of care is yes, I want to tell the patient about the 2-implant overdenture. However, I still have a lot of patients that just can't afford it. meaning that we still have to make a regular plain old denture. Does that mean I'm practicing below the standard of care? I don't think so. My personal standard of care, making sure the patient's fully informed, meaning that the patient knows their options. And if they say, well, maybe I can afford the 2 or maybe I can afford just 1, could you do that for me? Absolutely. The general idea of this consensus is that the 2 implant overdenture is a really wonderful first choice option for our patient. It is the overwhelming choice for our patients. And if I have a patient that's soon to be missing all their teeth, I'm at the point where I really just kind of refuse to do the treatment if the patient doesn't want to do implants. And the reason is that they're never really going to be that happy. Now, yes, there's always exceptions to that rule where the patient says, well, I've got a cousin, my aunt says that they never have any problems with their dentures. Well, we all have those patients. If you treat enough denture patients, you hear that story like on a day-to-day basis. What happens is that we know that the implant overdenture option is an outstanding one. And the big question is that how should you start out? How do we start out to make sure that we can go ahead and be ready? Most of us get started this way. We place our implants at the 22 and 27 position. I'm just looking at my slide. Oh, I made a little error there. 22 is supposed to be on the left side. So yeah, 22 and 27 position. And that's true. Those are pretty good go-to places for our first option for our patients. And once we know is that that's a pretty predictable, reliable type position for our implants and for our surgical procedures. There's not a lot of critical anatomy in that lower anterior ridge. In between the mental foramina, it's a very safe position. There's a lot of reliability there. It's also got a lot of background, historical evidence, etc. And in my practice, this is going to be the patient that just really can't afford anything more than just the 2 implant overdenture. And what we do know is that there is little evidence to really say implant number is a factor of our patient satisfaction. However, I can also tell you that the evidence does show that a simple approach, the KISS rule, applies to implant overdentures, meaning that easy maintenance, cleaning is preferred by patients, as opposed to, say, 4 implants in a bar or 6 implants in a bar. What I can tell you also is that there is no conclusive evidence indicating the ideal number of our implants for an overdenture. However, in my clinical practice, and speaking to many clinicians around the country and world, is that the general empirical clinical-based evidence indicates that somewhere right around 2 or more implants for the mandible and 4 or more implants for the maxilla is indicated. What does that mean? The middle of the road application is what you see here. If I'm, say, starting out, placing implants at the 22 and 27 position, just kind of eyeballing it, maybe 22 millimeters apart, approximately where the canines are in the patient's denture, maybe punch a couple of holes in a surgical guide, a copy of the patient's denture. Does that work? Absolutely, it works. However, I encourage you, check out this application. Using the classic kind of A, B, C, D, E treatment philosophy, what Carl Misch talks about, you can see here that the A and the E positions are approximately 5 millimeters away from the mental foramen. The C position is right here at the midline. We're not going to place an implant right here at the midline if we're going to do 4 implants. However, we're going to be kind of thinking about where's our other positions. The B and the D positions are split between the A and C and E. What I know is that after treating a lot of these patients where I go ahead and say, well, I know that the anterior mandible is an extremely safe position for me to go ahead and place dental implants. Not a lot of anatomy. Yes, there's blood vessels. Yes, there's nerves in there. I have to be a little bit careful, but for the most part, it's a very safe place to put implants. If I can put 4 implants in this configuration that you see here, the results with my patients are extraordinary. If the patient kind of looks at you and say, yeah, I'm pretty happy with that overdenture, when you see the difference in the patient's eyes, when you see the patient between the 2 and the 4 implant overdenture, you can really appreciate the power of just adding a couple more implants. You know, the hugs get a little bit, tighter. The kisses are a little bit sweeter with your patients because let's be real, why we're doing this is to really improve the patient's quality of life. I can tell you from my scientific publications, yes, 2 implant overdenture is equally as effective as, patient satisfaction as a 4 implant overdenture. But what I can tell you also from my clinical experience in my practice is that it just costs a little bit more money for me to put in 2 more of these implants versus just putting in 2 versus 4. Adding just 2 more to make 4 is just a few $100s more. Now, yes, if you're paying, $400, $500, $600 for a dental implant, that might be a concern. But looking at kind of a more affordable type of an implant, like a legacy implant, yeah, adding 2 more implants is a really awesome value add for your patients. So what I found from my experience in my practice is this is what I do a lot of these days. I put in 4 implants in the anterior mandible, somewhere between the A, B, D, and E positions approximately. And for some of my doctors that are listening to this presentation say, well, I'm kind of new to surgery. Yeah, this is a little bit more advanced. This is definitely a middle of the road application. You kind of have to feel a little bit comfortable with finding the mental foramen, dissecting down. If you don't feel comfortable and you still want to do this type of dentistry, get a surgical guide. Absolutely. Guided surgery is amazing. I love guided surgery. I do a lot of 3D printing in my own office. We have clinical courses and we teach programs on guided surgery. So look me up, fasttrackdentalce.com. And what happens here is that if you can go ahead and execute on this with a guided surgery, you don't even really need to be that crazy about finding the mental foramen. Now, asterisk, 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 yes. If you're doing guided surgery, you still need to feel comfortable with everyday implant surgery. So guided surgery is not a crutch for surgery. You still have to feel confident with your surgical skills. However, it does give you the leverage of being able to do more advanced cases. Meaning that if I go ahead and say, well, where can I also go more middle of the road, thinking about more middle of the road applications or advanced concepts for overdentures, go to the maxilla. On the maxilla, I generally recommend a minimum of 4 implants. And you can see here, if you kind of shoot for the number 3, the number 6, 11, and 14 positions, if you're thinking about those teeth numbers, 3, 6, 11, 14, those are very good, typically safe positions for dental implants for the maxillary arch. And this is what you would see here for our maxillary reconstructions. Very straightforward, 3, 6, 11, 14 type positions. Could be a palateless denture like you see here on the upper right part of the screen, or you can leave the palate on there if you want to be just usually using the implants just to help with stability. This is definitely a middle of the road application. And what I found from experience is that if you treat the patient well with this here on the mandible, it's only a matter of time before the patient starts asking you about doing the same thing for the maxilla. Start on the mandible, make the patient happy and thrilled, and you'd be amazed how many patients are ready to go to the maxillary arch once you're said and done. Now, certainly more of a middle of the road application is start thinking in this direction where you start doing bars, adding locators to bars. This is a wonderful type of way of doing dentistry. You can see here, this is a custom direct bar here on the screen. Really nice type of result. What happens with this is that to be on the safe side, if you have a patient with a denture that is bulky enough that you can do one of these types of bars, you need a little bit more space to do a bar, you need a little bit more room for parts and pieces. It's a wonderful way of restoring the maxillary arch. Why? It's because bone density is a little bit lower on the maxillary arch compared to the mandible. So typically on my mandibular arch, I'm doing individual locator abutments for these patients. On the maxillary arch, it's kind of a, 80-20 split, meaning 80% of the time is going to be more like this, 20% of the time will be like this. For those patients with low bone density, maybe it's an osteoporotic patient, maybe a patient with a big old bulky denture, one of these patients that wants their, denture to puff out their lips to make them look 20 years younger. Yeah, we all treat those patients. For those types of patients, you might need to consider a bar like this here from Custom Direct. What they can do too is just take a fixture level impression as part of your denture impressions, and then you go ahead and do your wax try-in on that on your model, send it to Custom Direct, and they'll design the bar so that way it fits within the denture. Put the bar in, and then your laboratory will make a denture that looks something like here on the upper right. Anytime that I do a palateless denture, I always want to go ahead and make sure I have a metal framework casting in there. On the mandibular arch, some doctors will say, well, Mike, do you do metal reinforcing framework for all of your overdentures? And the answer is absolutely not. It adds cost as well as complexity and also increases the need for prosthetic space. On my mandibular dentures, it's approximately 98% of the time I do not use a metal framework. Approximately 2% of the time I will. On my maxillary cases, if I am palateless, it's 100% of the time I'll use a metal framework. You just need it because there's a high chance of cracking and fracture if you do not have that metal in there with a palateless denture. However, on the mandible, if I do my bone reduction properly, I have enough sufficient prosthetic space, I do not need a metal framework reinforcement. Now, really where I spend a lot of time in my clinical practice is what you see here on the screen in front of you. I would consider this an advanced overdenture case. With using CBCT, guided surgery, or even just pilot guided surgery on my extraction cases, if I can leverage the modern technology, the 3D scans, as well as the surgical guides, I can reliably and predictably place implants on the mandible in the 19, 22, 27, and 30 positions. And on the maxilla, I can tilt those implants, same positions, 3, 6, or 7, 10, or 11, and 14. However, I can tilt those implants a little bit to try to get a little bit more distribution of my locator abutments. And we'll show you what that looks like here. This is kind of like a routine in my clinical practice, something like what you would see here on the screen. Now you can see here I've got implants approximately 19 position here, 22, 27, and this one is more like the 29 position. His 30 position was not ideal, but we were able to get a pretty good result. And you can see here across the board, bone healing looks good. You've got the locators in place. And if you feel comfortable doing this, you know that you've got enough bone above your inferior alveolar nerve, which a lot of patients that are soon to be edentulous do. For our patients that have been missing teeth for 30 years, you're probably not going to have bone back here past the foramen. But for my patients that are extraction cases, if I can socket a couple of implants, like in the mesial root here of 30 or 29, the mesial or distal root of 18 or 19, and then the canines, or maybe even the laterals, you get a phenomenal result. And it's hard to describe. Because yes, you know, the convention in dentistry is to say, well, you don't really need to do that. It's a lot of expense for your patients. It's a lot of complexity. Just try it. It's incredible. I can't describe exactly how amazing it is for your patients when you see their faces, when they feel the stability of this four-legged stool. It's just incredible. Give it a try. Like I said, make sure you've got a cone beam for these cases. Anytime I do implant surgery, it's with a cone beam. However, it's really important if you're going posterior foramen, meaning in the posterior mandible. And then also with using creative 3D printing, you can make your own surgical guides for $20, $30. So that really limits and, you know, kind of drives your cost down. And then using an implant that costs $200, $210 as opposed to $400, $500, you can do this on a regular basis in your clinical practice. And there's always cost ways to make sure that you manage your costs with your patients. This doesn't necessarily have to be double the cost for your overdenture cases. A lot of clinicians do a host of different incentives. You do 2 implants at full cost. Maybe the next 2 implants are at 50% cost, you know, of your implant fees. Whatever strategy you'd like to use in your office. To tell you the truth, how long does it really take you to drill 2 more holes? 10 minutes, max, 15, 20, 30, if you're really taking your time. In all reality, try it. It's an incredible way to do dentistry. As mentioned before, this is a patient that was completely edentulous for a long time. And I did a cone beam scan, kind of looked at her arch and said, wow, I might be able to put something here at the 19 and 30 positions. And take a look. Using my surgical guide, and this is kind of an older case because using one of these traditional suck down guides, but it was a 3D printed surgical guide. Popped it onto the ridge. You can see here I've got a couple of anchor pins. Just using the pilot drills I put in here. These are Legacy 2 implants. We put in 4.5s here in the posterior. I think they're 4.5 by, I want to say 8 or 10, something like that. I don't know the exact sizes, but I put 3.5s here in the lateral incisor position. In the 19 and 30 position, we put in 4.5s. Shorter implants in the posterior. And you can see here, look at the healing, look at the results. It's just magic. Doing a small amount of uncovery procedure here. Now I put on the healing abutments, put my locator abutments on, do my reline procedure, and here's my final result. Just an incredible way to treat patients. And then finally here, one thing that does come up on not so regular basis, but it does happen enough where if you design your implant properly, you can convert from locator or overdenture, you can convert to fixed. And this is a case here courtesy of a good colleague friend of mine, Nakul Rati. And he had a patient where there were 2 implants placed at the B and D position because the patient was thinking, hey, could I put implants in now, 2 implants, and maybe do a fixed bridge later if I really want to? Maybe I don't really like this overdenture. Absolutely, that's what happened here. Doing your implant positions properly, don't just guess at it. Don't just put them at the canine position arbitrarily. Think of it systematically. Treat your patients today because you never know how you're going to have to reboot them back into the diagnostic phase and readdress their additional treatment needs later. You can add 2 more implants later if you plan these first 2 implants properly. Maybe the patient can't afford a fixed bridge. Maybe they want to do a 4 implant overdenture. Pop 2 more in later. Bingo. You've just made that patient really happy. But in this case, we're going to go to a fixed prosthesis. Here's our mental foramen. Here's where we would ideally like to go ahead and place our additional implants, approximately 5 millimeters anterior to that foramina. And in this case, we had the ability to go ahead and angle those implants. So those implants were at a tilted angle for the tilted implant concept. And those anterior implants were placed at appropriate positions, not just the canine position, because if they were placed at the canine position, it would be a little bit more to the lateral. Canine 27 is here, 22 is here. This is B and this is D. This would be A and E. And then once we go ahead and place the 2 additional implants, it's pretty simple to go ahead and convert that patient over into a fixed restoration. So that's kind of been a background as well as a really kind of good fundamental type of a concept of what we're doing here, thinking about our patients both from a rudimentary beginner point of view, which would be just to start out with our 2 implant overdentures, 22, 27 position, and then also thinking about them for future treatment needs, whether it's maybe I want to leverage some of the 3D scanning, 3D technology, cone beam, computerized surgical guide, etc., and put 4 implants in today. Maybe the patient can't even afford a little bit of a deal. Like maybe if you say the first 2 implants are at full cost, the next 2 implants are at 50%, maybe they can't even afford the 50% off. They just got to just do the 2 implants now, and they'll do the 2 implants later. Being able to think about that efficiently is going to really tremendously improve your overdenture practice. Additionally, for me, in my clinical practice, is just tremendous to do the 4 implants as opposed to paying $500 per implant or $400 per implant. Yeah, you're paying an additional $800 in just implant or $900 in implant cost to do an additional 2 implants. So you have to charge your full fee. If you're placing implants at that $200, $210 range, popping in 2 more implants is an additional $400. Even if you say, you know what, you put the first 2 implants at full price, the next 2 implants are, I don't know, $2,000. Your same implant fee just for 1 implant. You're still coming out way ahead. And additionally, the X factor associated with that is that you've got a really happy patient. Minimal post-op adjustments. Many times I don't see these patients once every couple of years just to maybe check the retentive clips. Your number of intervals for your patients and your checkups go down when you increase your implant number. So at this point, what we're going to do is I'm going to go ahead and take some questions, and feel free, moderator here at Catapult Education, Lisa, jump in if we need to go ahead and tuck her off. But I've got a whole bunch of questions that are streaming in now. And if you're tuning into the webinar, you want to kind of shoot me a question, I can see them all up here on my computer screen, and I'll go ahead and just kind of take a couple here off the cuff here and just have some fun. Okay, here we go. This is from Dr. Abu Bakr Al-Mazri. Asked me a question of, thank you for the lecture, you're very welcome. I have a question. There is a way to correct a buccally placed implant with Locator. That's a very good question. If you have an implant that you maybe sent to a surgeon and your surgeon's like, I don't need a surgical guide, and all of a sudden the implant comes out like, way too facially, it's like way sticking out, and you say, oh shoot, what do I do here? You don't really have a lot of options. The biggest challenge is that the implants for an overdenture still need to be kind of thought of pretty well in terms of where the outlines of the denture need to be. And what happens with that is that you still want them roughly parallel to where the occlusal plane of the denture is. If the implant is way too buccal, then you kind of start have to thinking about doing a bar. If you have an implant that's way too buccal, chances are the other one is also really buccal. And the best thing you can do is go ahead and significantly change your angulation and then place the locators parallel on the bar. And what happens with that is that you can really, really change the angulation with the bar versus a standard locator, no. Now, if it's just a little bit of angulation, you can correct that with the extended range locator insert. Okay, so I'm going to take another question here. We have, all right, Winna Gallagher asked the question, is it retentive enough to have a 2-implant supported overdenture with a locator attachment on the maxilla? I always do 4 implants, afraid of not enough retention. You know, the interesting thing is that I've kind of seen a fair number of 2-implant maxillary overdentures that do okay. I don't know if I would necessarily go out on a limb and say I publicly advocate that, or I think that's a good idea. I really think it's a good idea to consider a minimum of 4 implants for your maxillary cases. In fact, I recommend 4 to 5, maybe even 6 for your maxillary cases. Can 2 work? Yes, I've even seen 1 on the maxillary arch with a palateless denture work. But remember, it's case selection, case selection, case selection. So as a general rule, I recommend a minimum of 4 whenever possible if you're planning on doing a palateless denture. If your patient just wants a little bit of retention and the patient is like, you know what, I don't know if I have the money to do all those implants, and you look at them and say, well, if you're okay with just having a denture the same way and you have the palate in place, if you're okay leaving that palate there, I can do just 2 implants, and I've done that. Place 2 implants, say the canine or premolar position, and it's just going to reduce the tendency of the denture going squish, squish, squish. The patient can feel like they're biting a little bit firmer. There's not as much dislodgement to the denture, and you're still using the palatal support. It's a little bit kind of a fringe concept, but I've seen it work. I've done it. The question is it supported by the literature? No. However, I have done it. Empirically, it can work. However, you run the risk of overloading your implants if there's just 2. So again, the general recommendation is at least 4 implants. So great question there. Another question comes up here. How do you tighten the triangular locator from Zest Anchor? This is from Zishan Salam. It comes with a tool, how much to tighten. Very importantly, make sure that you go ahead and you choose the retentive level for your implant system. So most of the implant direct line uses 30 Newton centimeters for their implants. However, there are other implant systems that you might have to use 20 or maybe 25. So make sure you look it up with your implant system. The triangular tool is available from your implant catalog. Okay, question here from Tyler Klein. What company do you use your surgical guides? To tell you the truth, I 3D print them myself. I use a 3D printer in my office. Make sure, send me an email if you have any questions about how to use 3D printers. It's a little bit beyond this presentation. However, there's a lot of really good surgical guide companies out there. Your laboratory might also have that option available to you. I encourage you check them out. You know, quite a few companies. I won't name them publicly here, but certainly just do a Google search. There's quite a few companies out there. Here we go. Just kind of zooming here. Okay, we've got 2 questions on a topic that really comes up on kind of a regular basis. Question, do you believe in flexure of the mandible? I get some varied info in the field. Some doctors believe in it, some do not, and there are concerns about cross-arch splinting. To tell you the truth, flexure of the mandible is real, meaning that when the patient opens and closes, there is a little bit of movement or change of the patient's mandible, meaning it's bone. There's a symphysis. There's suture lines when the patient opens and closes. If it was rigid, you wouldn't necessarily have a protective mechanism for the jaw and the teeth. So yes, flexure is real. It's been proven. Now the question is there a proven effect from flexure with implant prosthetics? And I have yet to see an article that can definitively connect flexure with causing implant complications or problems. And especially with overdentures, since you have a nylon insert, you have a minimal effect of the flexure risk. So that's a huge factor for overdentures. Got a couple more minutes here. We've got a really good question here. This is Dr. Albert Dos Samontes. How do you keep or key in the occlusion and midline position of the lower denture when you remove the soft liner material? That's a very, very good question. So what I do with my reline procedures is I have the patient wearing their soft liner. And yeah, if you do it properly, patient's comfortable, they feel good, comes back in. I take a little kind of marker, mark a spot on their nose, mark a spot on their chin, grab a little tongue blade, or I grab a caliper and I get that measurement. Now the next step is that when I remove the soft liner, what I do is sometimes, if it's a challenging case, I'll remove the soft liner from half of the arch. Then I'll go ahead and take compound or maybe like a sticky wax-like material or PVS, and I'll do some tissue stops on the right-hand side of the patient's denture. Then I'll remove that from the mouth, strip out the other side of the soft liner, and then repeat that tissue stop with PVS, or I'll use wax or compound, and then that way it doesn't change the vertical. I've got the correct position, things of that nature. It works really good on the maxillary arch. Also, remember on the maxillary arch, you're not really doing a lot of adjustment of the palate. Assuming you've got an immediate denture and you did ridge reduction, I typically don't need a lot of soft liner on the palatal surface because you're not changing the palatal surface. So you can always use the palate as a good landmark while you're relining. And then before I finish the reline impression, I hold my measurement up to the caliper or my little stick, make sure that those numbers are still corresponding correctly. Then when you do your reline, make sure you have the patient bite into centric, bite into a vertical dimension, etc. I found that's pretty predictable, Albert, and it works really, really well for me. Certainly, there's a lot of ways to screw up a reline. It's interesting. I see a lot of great clinicians that can handle implant surgery extremely well, and I've seen the same doctors really screw up a reline procedure. Sometimes in implant dentistry, we poo-poo the things that like the prosthetics because we are like, oh my God, I love doing surgery. Yeah, a lot of us do. And the problem is that we're like, I'll deal with the prosthetics later. And you can really screw up a great implant surgery with kind of quick or shoddy prosthetics. So make sure that you take your time, do the procedure really, really well. Okay, I've got a, really good question. This is from Dominic Tam. Do you commonly place implants immediately after extractions? Do you recommend placing subcrestal? If yes, how much deeper? That's a fantastic question. The answer is absolutely. A huge part of my practice is extraction and implant placement in the sockets. And what I typically do is that you have to know how much bone you need to remove or how much prosthetic space you need for your denture. So a locator needs approximately 9 to 11 millimeters from the top of the implant to the top of the denture. So that way you do not have a higher chance of prosthetic fracture, complications, and there's room for your parts and pieces in your locator abutments, your acrylic, your housings, etc. So on my cone beam, what I do is I go ahead and I measure from the top of the patient's natural teeth to 9 to 11 millimeters, and that's where I put my implants. Clinically, what I do is I go ahead and I have a surgical guide or I have a copy of their patient's immediate denture, do it in clear resin or whatnot, cut a trough on the lingual so that way I can see a measurement. Another way of doing it is that if you're comfortable with larger surgeries, you can open up a flap, take a Bowley caliper and measure 9 to 11 millimeters from the patient's natural teeth, and then take just a pencil, like a sterilized number 2 pencil, and mark a line at where that spot is, and then it's where you can do your bone reduction too. And then on top of that, absolutely, anytime that, say you don't need to do bone reduction, you definitely want to subcrest your implants, probably 2 to 4 millimeters. It's generally better to subcrest them a little bit more than you think. Now, that doesn't mean 10 millimeters. However, you are going to get a significant amount of ridge resorption after extraction. So definitely subcrest those. Great question, though. Here's a good question. This is from Benjamin Duplantis. If you're doing a lab reline for an overdenture impression, what does your patient wear in the interim? Typically, I do my lab relines either same day or overnight. So the patient, I look at them and just say, you know what? You can survive for 2 hours if it's the same day, or 10 hours, 8 hours if you're going to do it an overnight procedure. In all seriousness, I don't say it that way. I say, listen, we don't want to necessarily make you another denture. You're not going to be comfortable in it during that time period. I'd have to charge you a lot of money for that temporary denture. So the patient's just kind of gumming it. Now, I'll look at a patient straight in the face and I'll give them two options. We either do a same-day reline where they kind of have to be in the office all day, or they go to my lab and have it done, or I do a chairside hard reline. It takes a little while. And then if I have a really older patient that doesn't do well sitting in the chair for a long period of time, I'll give them the option of taking their denture away for a week, sending it in the mail to my lab, or having my lab technician work on it casually over the course of a week. And that only really works for my patients, like for their lower dentures. They haven't really been wearing their lower denture, very much. What I found from experience is that until you connect those locators, probably 80% of patients are not wearing their lower dentures if they're just got a soft liner in it. Of course, we as dentists think that they all are, but to tell you the truth, most of them aren't. And if they are, they're not really chewing or functioning on them. So most of the patients can kind of deal without it. Where most of the patients have issues if you take their dentures away for a week is the kind of the sunken in appearance, especially on our lady patients. They just do not want that for obvious reasons. So yeah, I don't have them wear anything in the meantime. And I think that is pretty much it, everybody. It's 6:30 out here in California, 9:30 here on the East Coast. I would like to thank everybody for tuning in here tonight. If I didn't have a chance to go ahead and answer your questions, by all means, send me an email. I'm welcome to do so. Certainly reach out to me on Facebook. You can look me up on Facebook. I'm happy to connect that way as well. LinkedIn, check us out. Facebook, Fast Track Dental CE is also a great way to reach me on Facebook. But it's been an honor and a privilege being able to present this here. And I certainly thank Catapult Education and Lisa for being able to host our webinar. And without a doubt, I'm very thankful for Implant Direct for being able to support this webinar and to bring high quality education for implant overdentures. I look forward to connecting with everybody next time. Thank you for tuning in.